Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right, guys, I welcome one and all in this class tonight, which is a very, very important class. Some very important concepts I'll be clearing tonight on thyroid. So let's begin. So these are certain key recommendations. It'll be good if we can read them later on. Okay, let's start with certain things, of course, are important, but you'll be able to understand this much better once I'm done with the other slides. So we'll come back to it, right? Now let's talk about the common thyroid function disorders in pregnancy. So you know there is overt hypothyroidism, which you find very, very common in Indian subcontinent, right? Then there is something called as subclinical hypothyroidism, in which TSH or free thyroxine, they will be deranged. And remember, when I'm saying T4, I'm not saying T4. Sometimes T4 is okay. Free thyroxine is the one which is creating problems. So subclinical hypothyroidism, that means TSH is okay, free thyroxine is decreased, or TSH is increased, but FT4 is normal. So this is called subclinical hypothyroidism. Then you can have thyrotoxicosis on the other hand. So gestational transient thyrotoxicosis could be that your TSH is suppressed, but free T4 is increased. And there could be overt hypothyroidism, in which this is suppressed, this is increased, and at the same time you have some reason behind it. Either you have a toxic nodular goiter or there is antibodies behind it. And what do you mean by gestational transient thyrotoxicosis? Usually in the first trimester, because of a similar attachment like an HCG, it seems as if TSH is also increased, and because of that, you might have a transient thyrotoxicosis kind of a situation, but usually it subsides on its own. Then you have something called a subclinical hyperthyroidism, in which there is a possibility of TSH being decreased, but FT4 still remains normal. Okay. So that was about some common thyroid function. Now let's take them one by one. Any confusion, please stop me. I'll answer your questions, right? Now, thyroid function tests in pregnancy. Let's talk about the reference ranges, okay? I'll not spend a lot of time because it's a pretty drag topic. So I'll try to make it as interesting as possible. Due to lack of time, I was not left with a lot to input my own notes in it. But putting it in the PPT, hopefully I'll get time to attach my notes along with it as well. Right? Before the exams, you just study those parts which I'm going to highlight for you. Now, what are the reference ranges for thyroid function tests in each trimester? To diagnose a thyroid dysfunction during pregnancy, trimester and manufacture specific pregnancy ranges for serum TSH and FT4 are recommended for correct interpretation for thyroid. Okay, so these things you have to take. It's reasonable. That's all you have to remember. It's reasonable that you set an upper limit of thyroid to 4. And I'll tell you where 2.5 is also important, right? For now, just remember this. This was thyroid function test. Basically, it is mostly lab bound. Whichever lab you're testing it from, accordingly, you'll be taking their parameter as the main parameter. But when you're talking about overall general, you can just say TSH is 4. That is your upper limit. Just a minute, guys. All right. Now, iodine and supplementation in pregnancy. How much iodine do we really need? So all pregnant and breastfeeding women should have a total daily intake of 200 to 250 micrograms of iodine is important. And ideally, the supplementation should start 3 months prior to the pregnancy or as soon as possible in pregnancy, but this is a must. India is endemic for iodine deficiency goiter, iodine deficiency as a whole. So since the time we started iodizing the salt, somehow there is improvement, but every next person, every third person is hypothyroid. Isn't it? Now, there's no need to read in so much depth. Just remember how much iodine is supposed to be taken and when should it be started. Okay, even this is not important. Now, is a universal testing required? International guidelines, GTG says it's not recommended because they are talking about the world or at least the European nations. We in India, we belong to this category. Subpopulations with specific risk factors who are known to have higher prevalence of overt thyroid disorders should be tested for thyroid dysfunctions. That means in India, if Indian society or if Indian gynecologists make a guideline that yes, universal screening is a must, will not be wrong. Okay. That's what I wanted to say. Now, what are the conditions which we are going to be discussing tonight? I'll be talking to you. Okay, guys, very important. At the very outset of the class, there are lots of you who are receiving messages on my from my fake ID. Please do not fall for those kind of messages. Please check with me my WhatsApp number. Also, I can put over here, but they can even use that number in some mysterious ways. So please remember, I'm saying it orally in the class. Just contact me on 852 1177 181. I repeat, 852 1177 181. This is my mobile number. Please, guys, contact me. Ask me directly. Do not fall for them. Do not pay them anything. I'm never going to give my notes apart from my app. There is a registered app I have on the iOS, also on the Android software in the Play Store. Other than that, you cannot, take my notes or my study material from anywhere, and it should not be like that. After a lot of copyright issues and privacy policies, I had to finally put it on the app, and I'm in no mood to give anybody anything downloadable or in the book format or anything else, guys. So be very sure that anybody who's trying to contact you, please find out the details of that person before making any payment. Okay, let's go forward with class. Personal history. Okay, so we're going to talk about thyroid surgery, goiter, thyroid nodule, previous overt or subclinical thyroid function, previous thyroiditis. So these are the conditions that should trigger the thyroid function testing early in pregnancy. And these are all the certain conditions which we're going to take in the class right now. So either she's had a previous surgery of thyroid, or she's got an overt goiter, thyroid nodule. Okay, previous overt or subclinical thyroid dysfunction, previous thyroiditis, known TPO antibody positivity, previous radioiodine ablation or recurrent thyroid disruptive medication like she's on lithium or amiodarone. Lithium is thyroid toxic. It actually is a disruptive medication for thyroid hormone, right? Then, of course, if she has signs like cardiac dysrhythmias or preconceptional weight loss or enlarging thyroid glands, these are all suspicious for thyroid function.